Welcome to another lecture by MedicoMedics, Respiratory Pharmacology. In this lecture, we will begin with a brief overview of respiratory pharmacology. We will discuss drugs used to treat asthma, chronic obstructive pulmonary disease or COPD. We will continue to discuss drugs used to treat allergic rhinitis, respiratory infections, and cough management. And as always, we will end with a summary. Now, let's take a quick look at respiratory pharmacology. So this is the branch of pharmacology that focuses on drugs affecting the respiratory system, primarily the lungs and airways. These medications are used to treat common conditions like asthma, chronic obstructive pulmonary disease, and allergic rhinitis, for example. Now, the main goal of respiratory therapy are pretty straightforward. First, to open up the airways, making it easier to breathe. Second, to reduce inflammation that can narrow or irritate the air passages. And third, to relieve symptoms like coughing, wheezing, shortness of breath, and chest tightness. All of these impact the quality of life. So to achieve these goals, we use a combination of bronchodilators, anti-inflammatory agents, and symptom relievers, each tailored to the disease process and severity. So we'll explore these drug classes in detail shortly, but for now, just keep in mind that the core approach is to improve airflow, calm inflammation, and control symptoms in a targeted, often inhaled way. Now then, let's look at the main classes of bronchodilators. These are the drugs designed to relax the airway muscles and open up the lungs, making it easier to breathe. So it sounds pretty important when we're talking about asthma. Now, bronchodilators come in three major types. First, we have the beta-2 agonists. These drugs activate beta-2 adrenergic receptors in the smooth muscle of the airways, leading to muscle relaxation and bronchodilation. Now, they come in short-acting forms like albuterol, which is great for quick relief during, for example, an asthma attack. And then we have long-acting forms like salmeterol, used more for maintenance therapy. Next are the anticholinergics. These block the action of acetylcholine on the muscarinic receptors. So this will then reduce bronchoconstriction, leading to bronchodilation, and reduce mucus secretion. So essentially decreasing the buildup of fluids in our vessels, while simultaneously reducing the constriction happening. This will logically open up the airways. So a common example for short-term use, talking about anticholinergics, is ipratropium. For long-term, tiotropium. And this is more relevant when treating COPD. Finally, we have theophylline, a less commonly used bronchodilator that belongs to the methylxanthine class. Now, it works by inhibiting phosphodiesterase, leading to the increase of cyclic AMP levels, which then in turn leads to bronchodilation. So while effective as a drug, theophylline requires careful monitoring because it has a narrow therapeutic window and its potential for side effects, etc. Now, each class here works through different mechanisms, of course, but all of them aim to improve airflow and relieve symptoms in these obstructive lung diseases. Usually, they're used in combination for better control, especially when dealing with chronic cases. So that's the bronchodilators. Now, in addition to bronchodilators, we also rely heavily on anti-inflammatory agents in the treatment of asthma and other chronic respiratory diseases. Why? Because inflammation is a key driver of our symptoms, causing airway swelling, overproduction or mucus production, hypersensitivity to triggers, etc. So we will then naturally want to use anti-inflammatory agents to calm that inflammation down and to prevent flare-ups. And when we talk about anti-inflammatory agents, there are three main types used in respiratory care that you should be aware of. First, we have the corticosteroids. These are the most powerful and widely used anti-inflammatory drugs. We have inhaled corticosteroids like fluticasone, and they are used regularly to control asthma and reduce exacerbations. However, for more severe cases, we use oral steroids like prednisone, and it may be used short-term to quickly reduce inflammation. Next, we have the leukotriene receptor antagonists like montelukast. So leukotrienes, or leukotrienes, however you want to pronounce that, are inflammatory mediators, and they're involved in bronchoconstriction and mucus production. We have a lesson on the inflammatory response. Make sure to check that out if you want to revise. So by blocking these receptors, the mediators of inflammation essentially, the drugs help reduce symptoms, especially in patients with allergic asthma. And finally, we have mast cell stabilizers, like cromolyn. They work by preventing the release of histamine and other inflammatory substances from the mast cells. While not used as often today, they can still be helpful in certain allergy-driven cases. But they are typically used prophylactically. So together, all these drugs form the backbone of long-term asthma control. And of course, quick relief emergency cases, we turn often to corticosteroids, for example. Now, together, they all target the root cause, which is inflammation, rather than just relieving the symptoms. So, drugs used to treat asthma, bronchodilators, we have beta-2 agonists, anticholinergics, and theophylline. Second major group is the anti-inflammatory agents. Here we had corticosteroids, leukotriene receptor antagonists, and mast cell stabilizers. Now then, let's take a look at the treatment for chronic obstructive pulmonary disease, or COPD. Now you will see some similarities to asthma, because inflammation, again, is a key player here. So COPD is a progressive lung condition marked by chronic inflammation, further by excess mucus production and irreversible airflow obstruction or airflow limitation. So it's commonly caused by long-term exposure to irritants like cigarette smoke. And unlike asthma, and this is key here, the damage is typically not fully reversible. Treatment here focuses on reducing symptoms, improving lung function, and preventing exacerbations. Several drug classes are used, often in combination for optimal control, and you will recognize many of these. So first, the bronchodilators, of course, which form the foundation of the therapy. We have long-acting beta-2 agonists, or LABAs, like salmeterol, which help relax the smooth muscles around the airways, making it easier to breathe. We have long-acting muscarinic antagonists, or LAMAs, such as tiotropium, And they work by blocking the effects of acetylcholine, reducing bronchoconstriction and improving airflow. So these are often used together, the long-acting beta-2 agonists and the long-acting muscarinic antagonists, in combination inhalers to provide more effective, sustained symptom relief. Then we have, of course, the corticosteroids, and they are used to reduce airway inflammation, particularly in patients with frequent flare-ups. So while it's more centrally used in asthma, they still play an important role in certain COPD cases, especially when combined with LABAs, or long-acting beta-2 agonists, like salmeterol, for example. Then we have the phosphodiesterase 4 inhibitors, like roflumilast, and they are oral medications that reduce inflammation by increasing intracellular cyclic AMP. And they're particularly helpful in patients with chronic bronchitis and a history of exacerbations. Finally, we have mucolytics, such as acetylcysteine, for example. They help thin and break down mucus, making it easier to clear the airways, especially in patients with chronic cough and with sputum production. So clinically, combination inhalers such as LABA plus LAMA are commonly prescribed as maintenance therapy for COPD. So these improve symptoms, reduce exacerbations, and enhance, therefore, the quality of life. However, the overall strategy in COPD is stepwise and individualized, with treatment intensity increasing as the disease progresses. Because remember, it's a progressive lung condition here. Now let's finish this section by talking about the treatment of allergic rhinitis. Now, allergic rhinitis is a common condition caused by an immune reaction to environmental allergens, like, for example, pollen or dust mites. Now, this leads to nasal congestion or sneezing, itching, a runny nose, for example, classic symptoms triggered by histamine release and other inflammatory mediators. So to manage this, we use several drug classes that target different parts of the allergic response. First, we have the antihistamines. So these drugs block histamine H1 receptors, helping reduce sneezing, itching, and runny nose. And they come in both non-sedating forms, like loratadine, and sedating types, like diphenhydramine, which can be useful at night but may cause drowsiness. Then we have decongestants like pseudoephedrine, and they help by constricting blood vessels in the nasal passages, which reduces swelling and congestion. Now, these are often used, I would say short-term, and can be found in many over-the-counter cold and allergy remedies. Third, we have intranasal corticosteroids like fluticasone, and they are considered the most effective first-line therapy for moderate to severe allergic rhinitis. What they do is they directly reduce inflammation in the nasal passages, improving all major symptoms. And then again, finally, we have the leukotriene receptor antagonists, like montelukast, and they block the effects of leukotrienes, which are chemicals involved in both allergy and in asthma. They're often used, these receptor antagonists are often used as an add-on, especially if the patient has both conditions. meaning both allergy and asthma. So in clinical practice then, fluticasone nasal spray is one of the most commonly prescribed treatments because it targets the underlying inflammation and provides a broad symptom control with minimal systemic absorption. But the best approach often involves combining therapies tailored to symptom severity, of course, and patient preference. Now then, let's cover the pharmacologic treatment for respiratory infections. So respiratory infections can be caused by a variety of pathogens, including, of course, bacteria, viruses, and mycobacteria. So the choice of drug depends on the underlying cause. First, we have the antibiotics, naturally used to treat bacterial infections of the respiratory tract. A common example is amoxicillin, often prescribed for community-acquired bacterial pneumonia, mainly when caused by organisms like Streptococcus pneumoniae. And for atypical pneumonias, caused by organisms like Mycoplasma, we typically use macrolides like azithromycin, which cover the less common pathogens. Next are antivirals used for viral respiratory infections. One example is oseltamivir, it's a neuraminidase inhibitor used to treat and sometimes prevent influenza, especially if it started within, 48 hours of symptom onset. Finally, the drugs used to treat tuberculosis, which is a serious and a chronic infection caused by Mycobacterium tuberculosis. So the first line here used to treat tuberculosis include isoniazid, rifampin, ethambutol, and pyrazinamide. And they are often given together in combination for several months to fully eradicate the infection and to prevent resistance. And among these four, isoniazid and rifampin are the cornerstone medications due to their potent bactericidal activity. We have a lecture on tuberculosis, of course, or will have a lecture on it. So go check that out for more details on the pathophysiology and treatment and diagnosis of tuberculosis. But all in all, treating respiratory infections effectively requires targeting the right pathogen. So diagnosis and pathogen identification will be key to guiding the appropriate therapy. Now let's look at the pharmacologic management of cough, which is a common symptom in many respiratory conditions. Now, cough can be broadly divided into two different types, and the treatment sort of depends on which one you're dealing with. We have first a productive or wet cough, which brings up mucus from the airways. We have a non-productive or dry cough, which doesn't produce mucus but is often persistent and irritating. And I know many students sometimes mix these up, but remember, wet, mucus, and dry, no mucus. So we use different drug classes to manage these. First, we have the antitussives. These drugs are used to suppress the cough reflex, typically at the level of the brainstem. They're especially helpful for dry, non-productive coughs that interfere with sleep or with our quality in life in general. Common examples here include codeine, which is opioid-based, dextromethorphan, I think that's the way you say that, a non-opioid alternative found typically in the over-the-counter medications, so it's accessible. Next, we have the expectorants like guaifenesin, and they are used to treat productive coughs. So they will loosen and thin the mucus, making it easier to clear from the airways. And this will help reduce chest congestion without stopping the cough reflex completely. Finally, mucolytics, such as acetylcysteine, they actually break down the structure of the mucus, reducing its thickness. And these are particularly useful in conditions with thick, sticky secretions, like chronic bronchitis or cystic fibrosis. So clinically, dextromethorphan is commonly used for dry cough, while guaifenesin is used when patients have a wet cough and need help clearing mucus. So naturally, choosing the right medication will depend on the type of cough and the underlying cause. So in summary then, respiratory drugs are essentially tools to maintain clean, open airways, helping you to breathe easier. So some of the conditions we mentioned here, all very high yield, include asthma, COPD, allergic rhinitis, respiratory infections, and cough. Now, all of these are far more broad and in their scope, and we have individual lectures on all of them, or will have, where we deep dive into the pathophysiology of them. And of course, more greater detailed management. Hopefully here you got an overview of how we treat these different pathologies. Some drugs highlighted here included the bronchodilators, the anti-inflammatory agents, and the mucolytics. And of course, naturally, the clinical relevance here is that these drugs improve breathing and control symptoms of both acute and chronic lung diseases. And that's the end of this lecture. Thank you for listening. Make sure to share, like, and subscribe for more videos.